Thank you for coming to this afternoon's webinar all about vaccinations and living with leukemia, MDS and MPNs. My name is Sophie. In case any of you haven't met me before, I'm the Advocacy Officer at Leukaemia Care, and I will be hosting today's webinar. I'll do a little bit of housekeeping and I will do a little introduction to the topic as well, and then we will get into our presentation. So in terms of how the webinar works, the chat function is open on Zoom, so you can type in your questions there. If you think of anything during the talk or at any point, then please do put it in the chat. One of my colleagues will be putting those questions into a live document for me for the Q&A part of the session. And if you are watching on Facebook as well, please feel free again to pop the questions into the chat, well, into the comments even, and they will get put forward to me, so I'll be able to see those, and hopefully I'll be able to cover as many of them as I can. The webinar will also be recorded, so this will be available within probably around the next week or so, to watch back at any point if there's anything that you'd like to look at after. So yeah, I'll keep that really short. So like I say, this is all about vaccinations, recommendations for what vaccines you should and shouldn't be having, and also it's come at that timely period of time where we're all being called for our autumn boosters and flu vaccines as well, so I'm sure we'll cover a lot of ground today. But yeah, that's enough from me. I think I will ask my speakers to introduce themselves now. So Helen and Alex, if you would both like to introduce yourselves, that would be amazing.
Yeah, so thanks, Sophie. It's lovely to be invited back by Leukaemia Care, so thank you very much. My name is Dr. Helen Parry, and I'm a consultant haematologist at the Queen Elizabeth in Birmingham, and I'm also an associate professor at the University of Birmingham.
Hi everyone, nice to see you all again. I'm Alex Richter, I'm Professor of Clinical Immunology at the University of Birmingham, and I work with Helen as well at the Queen Elizabeth Hospital and have a long interest in vaccination, particularly in blood cancer patients.
Thank you both, and with that I'll leave you to it, so if you'd like to share your slides, Helen, that would be amazing.
Lovely, thank you, Sophie. Right, so kicking off, so we're obviously talking about vaccination, very topical, as Sophie's pointed out, with the current seasonal vaccines that are available to us. And this is just a brief overview of what we'll be covering today over the next hour. So we're going to talk about what infections are blood cancer patients actually prone to, and then what type of vaccinations are available. And we've split that up into the seasonal recurrent booster campaigns that are ongoing each year, so COVID-19 and influenza. And then Alex is going to talk a bit more about additional vaccinations that can be specific for patients with blood cancer, and that will cover both the pneumonia vaccines and also the Shingrix vaccine against shingles. And then we'll also cover a little bit about vaccine safety and travel vaccines that are available, and what other protective measures are that we can implement to reduce the chances of infection risk for people with blood cancer. And then finally, we'll mention what studies are still ongoing and that we're looking forward to seeing the readouts for over the next year or two, that will probably sort of change management going forward, hopefully, and have some positive influence around patients who have blood cancer in their vaccination scheduling. So we know that patients with blood cancer are prone to infection, and this is actually very complex, and it's due to partly the underlying disease, which by nature of them being blood cancers are implicit and a part of the immune system, but also the different therapies that we employ and use to treat the disease can also influence the healthy blood cancer immune cells. And so it's quite complex and it's different for different patients, the degree of the immune suppression and also what types of cells are being suppressed within the immune system. And so as a blanket discussing sort of overall what immune suppression is like in blood cancer patients, it's quite hard to be, it needs to sort of be drilled down into individual patients and also their diseases. So the common infections that we do know often a lot of blood cancer patients are prone to, we often have good vaccines available for. So as I mentioned already, we have the seasonal vaccines, so flu and COVID-19. And then we also have specific vaccines against infections that can be problematic for patients with blood cancer. And that specifically is against varicella zoster, which causes shingles, and pneumococcus, which can cause pneumococcal pneumonia. But there are also some new vaccines that are on the horizon and things to look out for. And that's the respiratory syncytial virus, which is a common cause of the common cold virus. So COVID-19, so it's here to stay. We are all familiar with this now. And this little graph here is actually from the Zoe app, which many of you may have taken part in. They stopped collecting sort of the data for the graphical forms in July this year, which is why it stops at that time point there. But you can see that since Omicron variant came along, we have seen lots of peaks and troughs as the variant sort of the prevalence in the community or the amount of COVID goes up and down over the time course. And actually, the latest data suggests that as of the 17th of September, there are around 3,000 patients in hospital with confirmed COVID and 74 on intensive care unit. And actually, overall, if you look at the number that have currently got COVID in the UK, it's about 1.25 million. So actually, compared to right back at the beginning of the pandemic and pre-vaccination, we're seeing a much lower rate of hospitalisation, which is obviously good news. So the question I always get asked in clinic is why continue to get vaccinated against COVID? So partly it's because we can see that these variants are coming up and down all of the time. And with that, the risk of infection rate changes over time. But also we have new vaccines coming through, which are designed to tackle the latest variants that are in circulation. So this little graph on the left-hand side shows you what is currently going on in the States and the UK and Germany and Japan. And really, we've got 4 variants that going around in circulation at the moment, and they're all XBB or XBB derivatives. So they've come directly from the Omicron variant. And we started off when way back when in December 2020, January 21, with just vaccines that were based around the original ancestral Wuhan strain that was first identified for COVID-19. And actually up to the first 5 doses were just purely based on that original Wuhan strain. And then in last year in autumn, we were then introduced to what we call a bivalent vaccine. So that's where they took elements of the original Wuhan virus, and they also adapted it and put the first Omicron strain, which was BA1, into the vaccine. Following on from that, in spring of this year, we also had what we call the bivalent again, but they'd modified it further. And so as well as having the Wuhan, it then had a later Omicron variant covering BA4/5. And so you can see as the vaccine program has continued, we've obviously been adapting the type of vaccines that we are advocating and recommending for patients. And that is obviously trying to keep up and anticipate what is going to be prevalent and causing problems over the foreseeable months. So currently where we're up to now is we are still with the bivalent B1 and BA4/5, which was the same bivalent vaccine that was available back in spring. But also there's a new XBB mRNA vaccine that is literally just this week starting to become available in the UK. You don't get any choice currently in terms of which vaccine you get, and it's on supply in the centre or the GP practice of what is available. So just to point that out, because I'm sure that might arise as a question. So the other reason why we still continue to recommend getting further doses is because we know the immune responses wane over time, and antibody levels naturally would just fall. So when we first see an infection or when we first get a vaccine, we'll get an initial increase in the antibody levels that are generated. But then over time, that antibody level will drop unless you see the virus or you receive a further vaccine. And so that's the idea of having a booster campaign. So the boost with a further dose is seen even after you've had multiple doses because of that waning that occurs in between. And we know that in general, the higher the antibody response, the better the protection going forward. And that includes covering newer variants as they arise. The graph here just shows what we've recently learned. So this is from our CLL-VR study that we run in Birmingham, looking at patients specifically that have CLL. But this is comparing on the left patients that after they'd had a third dose of vaccine. And you can see in the blue, that is their pre-vaccine antibody neutralization. So that's how well they can deal with the virus when they see it, compared to on the right where you get the increment in pink after they've had the vaccine. And so if we look back to the original Wuhan strain of vaccine, which was given in dose 3, against Omicron, we're seeing a small increased level of protection, if you like, 1.7 times increase after that original Wuhan vaccine. But if we compare it on the right-hand side of the graph here to patients who received the bivalent vaccine that, remember, had that little bit of Omicron sequence in it as well, you can see here that we're seeing a much better increment in the ability to recognize that Omicron variant, 3.4-fold increase after they've had the dose of the bivalent. So this is really encouraging and tells us that actually even patients who have got blood cancer conditions that we know renders them slightly more at risk and immunosuppressed can still get additional benefit from having further vaccines that have specific strains or coverage for new variants as they arrive in the vaccine. So the other part of the immune system that gets a lot less attention is the cellular responses, and that's partly because it's actually much more tricky for us to measure cellular responses, and they aren't routinely tested in patients. But we do know from research studies that the cellular responses also boost nicely after each dose of vaccination, and they give additional and different protection to what antibodies do. And actually, just because perhaps somebody doesn't have an amazing antibody response, that's not necessarily the same case for the cellular response. So that's another reason why I continue to really, even in patients that we know haven't managed to generate such great antibody response, it's still important to continue to get a further dose of vaccine. And one thing that we really do know about the cellular responses is that they provide excellent protection against newer variants. So that what I mean by that is that actually, even if you have a bivalent vaccine that has, say, BA4 in it now, that will still confer at a cellular level. So when we look at the cells, good protection against these later XBB variants that are around now. So another reason to get a further COVID vaccine is that patient clinical pathway is different for everyone. And by this, again, we are learning. So we knew at the beginning of the pandemic and when vaccines first came around, for example, that patients who were on specific types of therapy weren't able to generate efficient antibody responses. But we're learning that as patients finish treatment and get vaccinated again, they then are sometimes managing to get very good responses. And equally, patients that perhaps had a dose of vaccine before they started treatment, their response subsequently to vaccines seems to be different. Where they've seen the virus before or the vaccine before, they've generated an initial immune response that can help them further going through treatment. So moving on to flu. So the flu vaccine covers 4 different strains of flu. So regardless of the vaccine type that you get, and there are several different ones, they all contain 4 different strains of flu in terms of their coverage. And that is anticipated based on what we are expecting to be in the circulating strains of influenza over the forthcoming season. So every year you'll be aware they're available from September, and you can get them through your pharmacy or your GP practice, and they're very safe and effective. And it's also important to point out that carers and household members are also eligible too and should be encouraged to go and have a dose of the vaccine. In terms of the types of flu vaccine, it's a little bit more complicated because there are several different types, but basically everybody who's under the age of 18 will be offered what we call a live vaccine, which is a nasal spray. And because that's live, it is recommended that immunocompromised individuals are avoiding close contact with children that have been vaccinated through this route for around 7 days. If you're in the age category of 18 to 65, you'll get offered a different vaccine. This can be one that has small amounts of egg in it. And so the important thing there is to point out to your nurse or pharmacist if you know you have an allergy to eggs. If you're over 65, you may be eligible for a different type of flu vaccine from this winter, and that is one that has got what we call a boost in it. So it's got an adjuvant in it that can really stimulate the immune system to generate an improved response to that vaccine. But if that's not available, there are alternative non-live vaccines that will be given. So in terms of treatment of flu, as I've mentioned, there are the 4 strains that are covered within the vaccine, but obviously there are other strains of influenza around. So it is still possible to get different strains. And if you are unwell with flu-like symptoms, it's important to seek medical advice. And obviously there's a lot of overlap there between flu and COVID-19. If hospitalized, there is an antiviral treatment called Tamiflu, which is available. But for all of these respiratory viruses, preventative measures can also help. So avoiding close contact with individuals who have got symptoms that are typical of common colds, reducing exposure in public places, especially if you're inside or in a room where there's inadequate ventilation. And we know from COVID that masks can actually help reduce the spread of the virus and the chance of contracting the virus if you're near somebody who has got it. Oh, at this point, I'll just pass over to Alex.
Thank you, Helen. So the flu and the COVID are what we now call our seasonal vaccines, but there are other vaccines that are available to prevent against common infections that are given at different time points, not to everyone in the population, but to certain disease groups. So a good example of this is the pneumonia vaccine or the pneumococcal vaccine. Now, unlike COVID and flu, this is a bacteria called Streptococcus pneumoniae. And I guess in some ways, similarly, there are 90 different types of this streptococcal pneumoniae. And what we do with vaccines is we vaccinate against the commonest types that are in circulation. Now, because this is a bacterial infection, we can treat it with antibiotics. It causes a number of different types of respiratory infections, so ears, sinuses, chest infections, and obviously pneumonia, and also some kind of joint infections. It's an important disease causing organism in that it causes 70% of all pneumonias in the UK. So preventing against it with vaccination is a key strategy, not just in the UK, but globally. Now, it's also a particular problem, I'm just going to mention it here, for some patients in the blood cancer cohort who don't have a spleen. This is a bacteria that's carried in the blood, and the spleen has a really important function in cleaning the blood. So if your spleen has been taken out, or if your spleen has been damaged with radiation, then your doctors will likely have you on a medicine called penicillin on a daily basis. Now, that preventative medicine is really good at preventing Streptococcus pneumoniae, and that's the rationale for that. So routinely, all patients who have acute or chronic leukemias are eligible for the pneumonia vaccine, but also for everyone over the age of 65. So for the leukemia patients, they are eligible for 2 different vaccines. Firstly is the Prevnar vaccine, which we use in children, and it's a kind of boosted, it uses all parts of the immune system to work, and that is protective against either 13 or 15 and possibly 20 this year different streptococcal pneumoniae types. And then what we do is a couple of months later give you a second vaccine, and this is the Pneumovax vaccine. And this works in a slightly different way, but provides some coverage against 23 serotypes. So slightly different strategies. For anyone over the age of 65, they will only get the Pneumovax vaccine. But for the leukemia patients, it's important to get that first Prevnar vaccine too. Helen. we could just move on. So the other vaccine that is age dependent is the shingles vaccine. And what is shingles? Well, it's reactivation of a virus called varicella zoster, and this causes chickenpox in childhood. And over 95% of us have chickenpox before the age of 20. And what the virus does is we don't clear it, but it goes and hides in neurons. And when the immune system becomes vulnerable, then it can no longer control the virus sitting there in our nervous system. And so it reactivates. But it doesn't reactivate as chickenpox. It reactivates just in that area of where that new nervous system is attached to. So you get it in these very specific distributions. And you can see a couple of examples here where you get these little blistering type rash. Now, shingles increases with age anyway, as our immune system wanes, but there is also a very specific increased risk in blood cancer patients. For example, in CLL, the risk of reactivation is in almost over a quarter of all patients. We know there's an increased risk in stem cell transplantation and if patients have GVHD, but also specifically for patients on ruxolitinib, there is an really quite significantly enhanced risk. So we were absolutely delighted when the shingles vaccine was licensed in the UK recently in a non-live form, which I'll explain in a minute. Now, why do we worry so much about shingles? Well, firstly, because it's incredibly painful or can be incredibly painful at the time. And you get this syndrome called post-herpetic neuralgia. And neuralgia means nerve pain. And so even though the virus is controlled again and the rash has gone, that nerve can remain activated and really, really painful for a long period of time. But shingles doesn't just cause a rash. It can go beyond the skin and cause problems with sight if it affects that part of your body, hearing if it affects your ear, or even inflammation in the brain if it becomes what we call disseminated. Next slide. So the Shingrix vaccine is the new shingles vaccine. And what's so important about this vaccine is that it is manufactured. The old vaccine was called Zostavax, and what this is a live vaccine or a live attenuated vaccine, which isn't safe for anyone that is immunocompromised. So the Shingrix vaccine is now recommended for anyone immunocompromised over the age of 50, with no upper age limit in the UK. For non-immunocompromised individuals, it's recommended now from anyone over the age of 65. And on your 65th or your 70th birthday, you would be invited to go for that vaccine. Now, it's a double vaccine. You have your first dose, and then you are given your second dose between 2 and 6 months after. And amazingly, even in immune vulnerable patients, it's over 90% effective in preventing shingles, which is an amazing reduction in illness. And the immunity also stays strong for at least 7 years after vaccination. At the moment, this is just a one-off course of vaccination. I don't know what the government might do later. You should receive the vaccine even if you've had shingles previously, because many patients with immune deficiency are at risk of recurrent shingles. And the Zostavax vaccine gives an even stronger boost than a natural reactivation of the infection. Thank you. So just a little bit on vaccine safety in blood cancer. And just to mention live vaccines. Now, not all live vaccines are avoided in everyone with blood cancer, and sometimes there needs to be an assessment of how immune competent you are individually. But what we tend to do is advise people to avoid in general, and GPs and pharmacists follow that advice. But if we think a vaccine would be very valuable to you, then we can have an in-depth discussion, as Dr. Parry and myself often do, as to whether we feel the risks outweigh the benefits. But what we worry about with a live attenuated vaccine is that the immune system can't control the vaccine. And so even though the vaccine can't reproduce in a host with a normal immune system, there is a risk that this virus, the vaccine, can then expand in you as an immune compromised individual and cause vaccine associated infection. You wouldn't be able to spread that, but for you, the risk would be that you get a vaccine illness. So that's why we worry about it. Now, the other thing that we worry about if you're immunocompromised is your ability to catch a live virus from household members. Now, this is unbelievably rare, and the evidence base around it is pretty poor. But on the whole, we recommend that household members or carers who have a live vaccine should avoid close contact with an immune compromised individual for 7 days. Now, this would have to be close contact, because if it was going to be spread, the vaccine, it would be through droplets, because an individual wouldn't be unwell, so they shouldn't be coughing. So the chance of transmission is very low, but this is just to be absolutely on the safe side. Now, the main issue where that comes up in questions is with children getting the flu vaccine of, parents or grandparents of immune vulnerable patients. Because the flu vaccine is live, you just need to be a little bit careful. So on the whole, we just say just no close contact with that individual for that period of time. Now, the other live vaccines that you will have heard of potentially that we use regularly mainly come in the childhood vaccine program. So measles, mumps and rubella, or rotavirus, which causes diarrhea, or smallpox. We don't often now use the smallpox vaccine, but I'm just raising the possibility of that because there's been an increased use of the smallpox vaccine to prevent monkeypox in some individuals. Now, chickenpox and the old shingles vaccine, which was live, is also generally to be avoided. The chickenpox vaccine is just a milder dose of the old shingles vaccine. It's not on the childhood vaccine program, but it is commonly given in private practice for many children. Now, the other one that you may come across if you're planning some exciting holidays over the next few years is yellow fever. This is required, as a compulsory requirement, a certificate in a number of countries. But for individuals with blood cancer, the yellow fever vaccine is not recommended routinely. And this is, to be honest with you, mostly where I have my discussions with Dr. Parry as around is it safe to give this vaccine? Is it a good idea? Can we send an exception that would be accepted by the country that individual is visiting? Next slide. So, thinking about where vaccination sits with infection prevention, we're going into the winter months. We know that all respiratory infections are increased over the winter months. And we're nervous not just about COVID and flu, but as Helen mentioned, the RSV vaccine's coming soon. We get much more pneumococcus, but also other bacterial infections. But on the whole, the infection prevention strategies in leukemia are fairly similar across all of these respiratory pathogens. Helen's already spoken about infection avoidance and how you can do that, avoiding crowded spaces or people who are actively unwell. Do take up vaccinations where you can. I think it's important to realize that you are immune vulnerable and how early identification and treatment of infection is important. This is where you mustn't have a stiff upper lip waiting for that pneumonia to develop. It's important to get treatment early and be assessed early to ensure that a nasty chest infection doesn't develop and become pneumonia. The other thing that we use is more active treatments as pre-exposure. You may have heard of Eversheld as a monoclonal antibody a year ago, and we can use that and other antibody therapies in individuals that don't make antibody responses and have an antibody deficiency. Many of you may be on these treatments. They're not available for all because they are limited treatments, and there is a whole funding panel that you need to go through to get them. But your hematology doctors will let us know if you are running into problems with infections, and we think that antibody therapy may be useful for you going forward. And the other thing that we do, which many of you will have been on, is use prophylactic antibiotics or antivirals or antifungal treatments to try and prevent that infection happening. Now, every one of you is an individual, and your individual risk will depend on how immune vulnerable you are, how many parts of your immune system are affected, and what your underlying disease is. It will also depend on how much exposure you have to infections. Do you have children or grandchildren that go to nursery? That automatically pushes up your risk. Are you a teacher? So are you exposed to classes of children that might have infections? But also, sometimes it just depends on how bad the infection is, and COVID was a good example of that. We had no host immunity to that, and so it was a bad infection. And we know this with flu. Some years, the flu virus is worse than others. So infection prevention requires this kind of combination approach to get us through. Next slide. So I'd just like to finish on a couple of research opportunities. I saw there was a question in the chat saying, you know, why was so little done in the immune compromised space? Actually, it's probably worth thinking that more work has been done around understanding vaccine responses in the immunocompromised during COVID than for any other time. The studies for COVID have never been done for flu or pneumococcus or RSV or any other vaccines. So actually, we've learned a huge amount from COVID. And there's still opportunities to understand vaccine responses in patients with blood cancer. Some of the studies that are ongoing at the moment, there is a monoclonal preventative treatment study by GSK called Protect V that's open at a number of sites, giving sotrovimab treatments in advance of infection. There are two Eversheld studies that, well, Rapid Protection is closed at the moment, but is hopefully going to be reopened this autumn with Eversheld 2. And there is the Supernova trial also recruiting. So those are all for preventative treatments. Dr. Parry was leading the IMPROVE study, which looked at whether a suspension in one of the treatments in the BTKI treatments improved COVID vaccine responses. That's actually closed for recruitment, but will give us really important information as to whether stopping your treatment for just a short period of time is, one, safe, and two, helps your vaccine response. Next slide. And then the last study, which I'm involved in, and Helen is also involved in Birmingham, is the Stravinsky study. And this is where we're trying to understand the individual risk of someone for COVID. We've done quite a lot of research looking at what we call cohort studies. So we've looked in a number of large blood cancer cohorts, we've looked in liver cohorts, we've looked in immune deficiency cohorts, we've looked in renal cohorts, and we've really understood how, as a group, individuals have run vulnerable. But from all those studies, we've learned that some people that we think are really vulnerable actually sail through COVID and have no problems at all. Whereas there are some individuals that have a really awful time, and being able to predict who as an individual is at risk remains very difficult. So we're recruiting 3,000 individuals across the UK from 11 different sites. So do look us up on the internet and see if there is a site nearby that is recruiting, if you would like to take part in this study, which will be running over the next 18 months. So I think I will leave it there. I hope that is a reasonably comprehensive run through of what is available. And, you know, Dr. Parry and myself would be really happy to take some questions.
Oh, that's brilliant. Thank you both so much for that. I think we've definitely covered a lot in that presentation, and I think that yeah, it sparked quite a few questions. So I will do my best to ask as many as I can. But just to let everyone know, there will be an opportunity, there will be an email address at the end for advocacy. So if there's anything that you'd really like to know, please do send those questions on, and they'll come through to myself, and I'll do my best to get back to you after the webinar. Going back to sort of, you know, the COVID boosters at the moment, it seems to be a common theme that we're hearing, that people are having various reactions to the boosters that are taking quite a while to recover from. I've heard from patients who it's taken them anywhere between a week, maybe to around the 3-month mark in terms of recovery. I suppose my question is twofold. I think the first part of that would be, why do those reactions happen and why are they so extreme? And the second part of that would be, you know, should that cause anyone to feel any reluctance about taking further vaccines if they're having these reactions?
Well, the reason that's happening is the body is remembering that they have seen that vaccine or the infection associated with that vaccine previously. So to some extent, it's actually quite good news, because that means they've been able to mount an immune response, and they do have some immune memory. Now, every vaccine will be slightly different as to where you are in your vaccine cycle and how much that response has waned and what else might be going on at the time. But what we do know is, overall, an individual's risk from infection is higher than their risk from having a bad time from the vaccine. So we fully accept that some people may be unwell for quite a few days following the vaccination. Most aren't, by the way. Most aren't, but we do know that some people are unwell for a few days. But that doesn't necessarily mean unwell the next time. And we do just worry that if you get COVID, you will be even sicker, if that makes sense. So it is a balancing act. And on the whole, we recommend vaccination. Helen, do you want to add something to that?
Yeah, I get asked this question an awful lot. It seems to come up and I don't know. So if you look back at the studies after sort of the second dose of vaccine across all population studies, it was said that up to about 60% of people did get some side effect to that vaccine. And that was sort of typical up to a week anyway. So I think sometimes we're perhaps reading into the fact that we've got an underlying immunosuppression, and maybe that's why we're assuming that that's why we're getting these side effects. So that's one thing I sort of try and point out to people. But yeah, I agree with everything that Alex has said. It's far worse to get the actual infection than the vaccine. mRNA vaccines are cleared very quickly from your body. So what we're actually feeling is our immune system. It's our immune system recognizing that vaccine. It's not the vaccine hanging around. It's actually our body reacting to it, which, as Alex said, is generally a good sign. And it might not necessarily be the component of the immune system that, like I mentioned, antibodies that we all look for, but actually our immune system is really complex, and there's lots of other parts to it that will be responding to that dose of vaccination.
That's brilliant, thank you. Yeah, I think, like you say, it's better to have some protection than none. So encouraging vaccines is very important. And I think we had another question as well, sort of similar, but with the results of the reaction from the shingles vaccine as well. So I guess that's the same principle of it sparking, you know, an immune reaction, and it's just your body's way of responding to that. So thank you both for covering.
So, Sophie, when you have a reaction, it provokes an inflammatory response, but that inflammatory response is milder than an infection.
Yes.
Yeah.
So it is the things that make you feel unwell are the components of the immune system that we would recognize. We call their chemical signatures called cytokines.
Mm-hmm.
And what they do is trigger what we call a flu-like response. And, you know, but unfortunately, the parts of the immune system that are being triggered by the vaccine can't differentiate between why it's being triggered. We call it our innate immune system. So it just does what it's told every time, and it can't tailor it and say, oh, this is vaccine, we like this one, so I tell you what, we won't make any side effects. And actually those extra signals boost the memory and the response and how long that lasts in the future. So to some extent, being a bit unwell with a vaccine is probably expected and might be a good thing.
Yeah, definitely.
I was going to say as well, Shingrix has been really cleverly designed and has got this boost that I talked about with that new flu vaccine that's come along too, which really, so it's known that actually it is a vaccine that does make people feel quite rough when they have it, but that is because we're trying to really do our best to stimulate the immune system.
Oh, that's really good to know. No, thank you both for that. So I think as well, there's been a few questions. So I know with the rollout of the autumn boosters, a lot of people have been offered both their COVID and flu together. There's been a couple of patients who are a little bit concerned about having them both together, maybe concerned about having a worse reaction or anything like that. Would you have any advice for anyone who's feeling a bit concerned about that?
There was a study done during COVID looking at the safety of putting the two together. And it was shown to be safe, and there may even be some hint that if you put vaccines together, because they're both producing a slightly inflammatory response, that you may be boosting both of them. So it is not uncommon in practice to give vaccines together. So if you think about the children, the infants, we give 6 in one go. So it's quite common for vaccines to be synergistic. What I would say to people is if they had if they are concerned, there is no reason why I can't split them up. You know, you have that choice and you have that right. And, you know, you may want, you know, if you feel that it's just too much for you and you were so knocked about last time that you'd rather take them one by one, then I think that is your choice to do so. There's no evidence that will improve things, but certainly it's worth a try.
Right, thank you. Yeah, I think always important to remember that you have got a choice in those things, and that if you have any concerns, either speak to the vaccines nurse or the GP or even your consultant as well for a little bit of advice. It's always worth an ask. Brill. So going a little bit, I might go between a few of the different jabs here, but we spoke a little bit about the pneumonia vaccine. What is the remit for sort of boosters for that? Is there a certain time where someone needs to have a booster, or are they not recommended for that? How does that work?
It's not straightforward, actually. There's no recommendation for boosting. What we do know is if you've had the pneumovax vaccine, you shouldn't be revaccinated within 5 years. Now, sometimes if you are in your haematology clinic or if you go to an immunology clinic, we may look at your levels to the pneumonia vaccine and we may recommend a booster. But on the whole, it is not routine. And actually the government guidelines on it are really grey. They don't say it can't be done, but they do say it shouldn't be done within 5 years. Helen, what's your practice? I mean, do you routinely check goggles?
No,
Straight grey territory.
No, I do. If I've got somebody, well, you know, because I send them to you, but if I've got somebody who's really running into problems with infection, then we will check the sort of innate the immunity, sorry, to pneumococcus. But as you say, it's not routinely practiced that we revaccinate against pneumococcus. I think we know that the order that you pointed out in the talk, you know, given the Prevnar 13 before the pneumovax, we think that that's very important. And I also, if I find patients in clinic that have had pneumovax, I always make sure I then recommend Prevnar a dose of. If they've missed the opportunity of having Prevnar, you should still get it subsequently. And that usually happens because we've diagnosed them after they've had the pneumovax vaccine. And obviously in England, everybody's routinely offered pneumovax at the age of 65. So that's why that scenario crops up quite a lot. But yeah, in terms of boosting, again, later on, there's no sort of guidance on it. And it's something that actually we've discussed, haven't we, Alex, and that we'd be really interested to look at and research ourselves. But currently, it's not recommended.
Okay. Yeah, very interesting. So I think that's sparked a little question for me as well. So in terms of patients who perhaps have had their pneumovax before perhaps going through transplant or anything like that, is there are there different circumstances for those patients?
I was going to say transplant is a different scenario because we're basically giving somebody a whole new immune system. So there we do revaccinate, and we go actually back to sort of a childhood vaccination schedule, and the same now with patients that have received CAR T therapy. So where we're really going for it, sort of knocking down the immune system and then allowing it to come back, if you like. In that scenario, we tend to start from scratch again. Alex, do you have anything to add there?
No, just and to remember the childhood vaccine schedule is slightly different. We use the Prevnar vaccine, but we use 3 of them. And some of the research Helen and I have done, gosh, this was all pre-COVID, Helen, wasn't it? And the studies that we wanted to do were looking at giving a similar vaccine regimen to adults and the immune vulnerable to try and get that response to last longer. I think COVID's probably going to give us the opportunity to go back and look at some of these other vaccines in more detail in the immune vulnerable. And from my point of view, I think it's, when people are bringing out new vaccines, why vaccinate and do studies in those people that don't need to be vaccinated, in the healthy individuals? I'm really keen that we advocate to MHRA and all the groups to say, actually, you've got to have an immune compromised group in this to show what's happening. The paediatricians have been quite successful at that, and you've got to look at paediatric studies as well. And I think there certainly is something we could all do to kind of push the agenda for vaccination and the immune vulnerable.
Yeah, definitely. And as someone who is post-CAR T myself, that is very interesting. So thank you for that. So we are getting quite a few questions still coming in, so I'm just trying to field a few of them. We have had one specifically, and we've spoken a lot about leukemia specifically here. We have had a question from someone who has asked more so towards MPN patients. Are there any other specific recommendations for patients with MPNs in terms of vaccines that we haven't spoken about?
Helen, do you want to take that?
Yeah, no, there aren't. And actually, some of the studies that came out during COVID were really informative for MPN, because it was a group that really, I don't think, had really been studied before. And yeah, and actually on the whole, we were pleasantly surprised. It was pretty decent immune responses. There are certain drugs that we know can be problematic. And so, like Alex explained, the ruxolitinib, that seems to be very sort of puts you at higher risk, certainly, of shingles reactivation. But on the whole, generally, immune responses weren't too bad. But they're not, I would say that MPNs aren't a really well-studied group. And that's probably partly because patients don't tend to run into the same degree of problems with infections overall, I would say, compared to some of our leukemia and lymphoma patients and some patients that have been treated with drugs that really sort of hammer individual parts of the immune system.
That's great, thank you. And just to answer the question that's just come in, MPN is myeloproliferative neoplasm, if I can get that out. Fab. So, and just looking in the chat as well, just to skip back one, in terms of the discussion of childhood vaccines, someone has mentioned that they've just had all of those redone, but no one has advised them about the shingles vaccine. So should they speak to their GP about that?
I'm just seeing the question. If it's Elizabeth, so yeah, basically anyone that is immune compromised or has been immune compromised will be eligible from the age of 50. So yes, they would be eligible. So definitely worth speaking to the GP, but make sure you get the non-live vaccine, the Shingrix vaccine. Just you know, until we know how immune vulnerable you are, it is always better for any blood cancer patients to have the non-live vaccine.
That's great, thank you. And I think that's a good one as well. And someone asked earlier, can you get shingles if you've never had chickenpox?
Nope. You need to have the virus. But what I would say here is, I bet you have.
Yeah, I was going to say that.
Lots of people have had one spot or two spots or something like that in childhood, so that it's just been missed. And it is highly, highly, highly unusual to have not had chickenpox. What we find when we look for antibodies against chickenpox, for most people they're there. Very, very occasionally, we don't find them and people get shingles. But if you look on a high sensitivity assay test, they did have antibodies there. They've just waned to a level where we don't routinely test them. But most people have had chickenpox at some point in their life.
Yeah, very interesting. Like you say, it's if you see one or two spots, you might not necessarily think anything of it. Yes, very interesting. We had a question earlier from someone who is in remission from AML. They've asked if they're still considered as having leukemia. So I'm guessing in terms of eligibility for vaccines and things like that, would someone who's in remission still be eligible for some of these?
I think it depends on how far out they are.
Yeah, no, I agree. I mean, I think we generally find that patients who have required treatment for AML and ALL actually subsequently develop or reconstitute or bring back a fairly normal immune system and don't tend to run into too much problem actually going forward. It's an interesting area as well. I talk a lot with one of our consultants, Lindsay George, about the teenage patients and whether we should be revaccinating them after acute leukemias. But if you look at the Green Book, a diagnosis of acute leukemia comes under an immunosuppressant, so therefore you should be eligible for the vaccines that we've already talked about. But I think if we're talking about a long term and they've been in remission for a long term, then no, I would anticipate that they would have a relatively normal immune system.
Brilliant, thank you. So I think I'll do one last question just to round things off. In terms of finding out your vaccine response, whether it be to COVID or to some of the other vaccines that we've spoken about, how would someone go about getting that checked?
So there are definitely commercially available tests that you can pay for to check your COVID antibody status. I can't remember the company. I used to know the company off by heart because people used to ask all the time, but if they Google, they would be able to find a test for COVID antibodies. I think I would caveat that with saying that it's a useful tool, I suppose. If you've got no antibody response, then you probably can infer from that that you might be at risk going forward of not just COVID, but other infections. But in terms of the sort of level of antibody response, if you generate a positive antibody response, what nobody's ever really been able to show is what that equates to in terms of a protective level. So to me, it's almost a black and white assay still. I think it's have got an antibody response or you haven't got an antibody response, and that perhaps can inform and help perhaps in your decision making in terms of the preventative measures that we talked about, and avoiding sort of close contact with patients, etc. But in my opinion, patients generally know if they're in that group. They've suffered from infections before, and they're fully aware. And COVID is just another respiratory virus, basically. I mean, it's the same groups of patients, unfortunately, that we have looked after for years with risk of infection that are at risk for COVID-19 as well. I don't know if Alex has got any thoughts on that, but
so
that's my...
This is actually what we're trying to work out with Stravinsky study, is how does an antibody test result predict your individual risk? Does it or doesn't it? And if it doesn't, what other immune tests might? Or actually, is it just knowing something different, like what is your age, what is your gender, and what is your disease group? Is that as good at defining your risk? So that's why, we're doing this study to be able to help going forward, to individualize that risk rather than thinking across the board. At the moment, if you have no antibodies, it doesn't mean you're going to have really bad COVID, but it probably means that you are more likely to than someone that has really good antibodies. Now, some of that may not just be because you've got antibodies. It tells us something about how immune competent you are. And if you're not producing a good immune response to a vaccine, that's telling me that you are vulnerable to not making a good immune response to an infection. So if some of you are unlucky enough to have come to my clinic, we quite often vaccinate people. We test vaccinate because that's giving me a surrogate marker of how immune competent you are.
That's brilliant. Thanks, Alex. And I think, the results of that study will be very, very interesting and also very helpful for a lot of people going forward. Right, thank you both so much for that. I know we had quite a few questions come through, so I'm sorry if I've missed quite a few of them, so I'm really sorry about that. But like I say, we'll go to some end slides now, and we'll run through a couple of leukemia care services, and like I say, any burning questions or anything like that anyone's keen on asking, please do send them through, and we'll pop an email on that you can send them through to me, and I'll see what I can do for you. So we've got lots of information sources from Leukemia Care. We have everything from these webinars that we run to our newsletters and magazines, and also our website information as well. So you can check all of that out, and you'll find all of our latest updates through there. And as we mentioned at the beginning of the webinar, we have got some updated blogs online for you now. So we have our COVID and flu jab update, and also our Shingrix one as well. But if anyone does have any queries about the eligibility or anything like that, then please do get in touch, and we'll see if we can clarify that information for you. As I mentioned, we've got lots of booklets. These are specific to types of leukemia or MDS and MPNs. So if there's anything like that you'd be interested in, then you can order them for free through our online shop. We have lots of support services. So we have our helpline and WhatsApp service, which I look after. And we also run lots of different support groups where we cover a few different topics with welfare and advocacy support as well from myself and my colleague. And of course, we have a counselling service and also online forums too that you can join and speak to others who are going through similar situations to yourself. Support groups, as I said, we've run quite a few of them. We've got quite a few coming up over the next few weeks and months. So if any of those are of interest to you, then do go onto the website and you can register for any one of those that you'd like to. And the buddy scheme, of course, it's really important to be able to talk to other people who understand what you're going through. So that's why we set up the buddy scheme. It's a really lovely service. So if you would like some support from someone, then please get in touch about that. Or if you think that you could support someone and be a buddy to someone who's maybe been recently diagnosed, then please do let us know if you'd like to get involved with that, and we'll send you some more information. The advocacy service, that's me. So off the back of this webinar, if there are any questions or if anyone is struggling to access any of their vaccinations, then please do get in touch and I will see if I can support you with that. And like I say, we also have a welfare officer who can support with anything to do with benefit entitlement or financial grants, anything like that. Then again, please do get in touch. And that's our email address as well. So any questions after this webinar, do send them to advocacy and we'll pick them up. The counselling fund, again, so we can provide funding for up to 6 sessions of private counselling to anyone who's affected by leukemia, MDS or MPNs, and that includes family members as well. So if you are interested in that support, you can have a look online and there is a bit more information about it there. And of course, keeping up to date with everything that we're doing. We're very active on Facebook, Instagram and Twitter, and our website is always being updated as well with any new events or updates that we've been working on. So feel free to check those out. And fundraising, of course, so we wouldn't be able to run any of these webinars or any of our services without our amazing fundraisers. So there are a lot of ways that you can get involved, and that can be anything from a cake sale to taking part in a marathon. So anything that you want to get involved in, then please do let us know, and we'll see if we can support you with that. And yes, so any support or information that you need after this webinar, please do give us a call on our helpline or pop an email over to us, and we will absolutely do our best to support you in every way that we can. So that's everything. So thank you everyone for coming, and I hope that you found this helpful. Bye.